Okay, can everyone see my screen?
Yes, madam. We can see the screen here.
Yeah, thank you. So let us start today's session. Hi, let me introduce myself. I am Dr. Maimuna. Please please mute yourself. If you have any doubts, you can contact me or you can unmute and ask me. Okay.
Okay, madam.
Yeah. So coming to our session today, today's session is a management of nausea and vomiting in pregnancy and hyperemesis gravidarum. This is a green top guideline we are discussing today, and this is published in February 2024. Here now you can see this. This is the guideline, and this is a green top guideline. So green top guidelines are given from the RCOG. So usually in India we follow RCOG and ACOG guidelines. For some reasons, most of the things we will be following ACOG and RCOG. Okay, now coming to the definition of nausea and vomiting in pregnancy. NVP is nausea and vomiting in pregnancy. Coming to the definition, it is a symptom of nausea or vomiting during pregnancy when the onset is prior to 16 weeks. Okay, prior to 16 weeks is important. So whenever a symptom occurs prior to the 16 weeks of gestation, then it would be nausea and vomiting of pregnancy. It is usually common in many of the patients, 80 to 90% of the patients, they will experience the nausea and vomiting. Okay, so now coming to the hyperemesis gravidarum. So what is hyperemesis? The name itself suggests hyper. Hyper means more. This is the severe form of nausea and vomiting in pregnancy, and this interferes with the quality of life. Whenever a condition or a symptom interferes with the quality of life, it is known as a hyper, like AUB. So abnormal uterine bleeding or heavy menstrual bleeding, you will be having interfering with the quality of life. The same itself applicable in the hyperemesis gravidarum also. You cannot say, if the patient comes and says, I'm having two vomitings and I cannot do my work, I'm just getting so much fatigue, I'm just sleeping all the time, then you cannot say this is nausea and vomiting, because it is already interfering the quality of life. The quantity of vomiting is not important here. Okay, and then you have to ask her if she is able to eat and drink normally. So in the regular OPD we can see the parents of the pregnant women saying that she is not eating anything, even if she drinks water also it is coming. That itself shows that she is suffering from hyperemesis gravidarum. Okay, so now we will revise the definitions. Nausea and vomiting is any sort of vomiting prior to 16 weeks of pregnancy is known as nausea and vomiting, but that is NVP. But if the vomitings occur after 16 weeks of gestation, like the first onset is after 16 weeks, then we should rule out other causes. So what might be the other causes? It could be some liver problems, like any acute failure of liver or acute liver failure. Okay, AFLP, such things would be there, or any hepatitis, or any appendicitis, any pain abdomen. So such conditions we need to rule out if it is after 16 weeks. So 16 weeks is the point to be noted. Okay, so previously hyperemesis gravidarum, we used to have another definition. What is that? It is a severe or persistent vomiting leading to dehydration, weight loss, and electrolyte imbalance. This used to be there previously, but what happened in recently February 2024 guideline, they have given, no, we cannot measure a patient's vomiting, or we cannot measure it according to weight or electrolyte abnormalities. Only with the quality of life we need to measure the hyperemesis gravidarum, so that we cannot miss any case. Okay, then what is the mechanism? Why there is a hyperemesis? Why there is a nausea in or vomiting in pregnancy? Anyone, can you tell me why there is a vomiting in pregnancy?
Because of beta HCG effect, madam.
Yes, very good. So it could be due to human chorionic gonadotropin hormone, that is beta HCG hormone. But what the new guidelines or what the mechanism says is, In the hyperemesis gravidarum, you are having another GDF, that is growth differentiation factor 15, is also increased. That is hypersensitivity to the vomiting hormone. Vomiting hormone is the growth differentiation factor, GDF 15, has also taken involvement in causing the hyperemesis gravidarum. So, as he said, nausea and vomiting is due to HCG, but hyperemesis gravidarum is due to both HCG and GDF 15. So, what are these two things? These are made when the genes in the placenta are activated and circulating levels have a peak in the first half of pregnancy. That is the reason she is having vomitings less than 16 weeks of gestation, and they will usually decrease by 20 weeks of gestation. So usually the pregnant women stop complaining vomitings like around 4th or 5th month. That is around 20 weeks they'll stop complaining of vomitings. Why? Because placenta is at its peak in the first half of pregnancy, and the hormones are also at its peak, that is the HCG and GDF 15. So this is the mechanism of nausea and vomiting in pregnancy or hyperemesis gravidarum. Now coming to the diagnosis. Okay, you can ask me why I have skipped the signs and symptoms, everything I have skipped. Why? Because in diagnosis only, you are telling so much about the signs and symptoms of how the patient presents to you, how she is presenting with the nausea and vomiting. You can diagnose it. That is the reason immediately we shifted to the diagnosis. So, as we have already told, nausea and vomiting in pregnancy can be diagnosed. That is, NVP is diagnosed when the onset is prior to the 16 weeks of gestation, and prior to 16 weeks is important, and other causes of nausea and vomiting is also to be ruled out. So other causes are also to be ruled out. Then only you can say it is a normal NVP due to hormone, due to the HCG hormone, so that you can treat her with simple antiemetics or something. If you have not ruled out any other causes, like if she is having any intestinal obstructions or if she is having any appendicitis, they might be missed and it could be life threatening. Okay. Then comes hyperemesis gravidarum. So hyperemesis gravidarum, how you are going to diagnose? Most of the things are clinical. Previously, they used to say ketonuria should be there. So if the ketones are positive, then you can diagnose hyperemesis gravidarum. But now a new guideline says ketonuria should not be used for diagnosis. It should be known used for only severity, or you can say that she is going into dehydration. For that point, you can use a ketonuria, but for the other things or for the diagnosis, you cannot use the ketonuria. So how it can be diagnosed? Usually the symptoms start in the early pregnancy. Nausea and vomiting are severe. So they are not very less. They are very severe enough to cause an inability to eat and drink. Similar to that of the definition, inability to eat and drink normally, and it limits the daily activities of the living. So it is also limiting the daily activities of that patient. Then all these comes under hyperemesis gravidarum, and the signs of dehydration are only just contributory to the diagnosis. They does not itself confirm the diagnosis. They are just contributory, extra addition to that of the diagnosis. Next, coming to the nausea and vomiting, usually starts between 4th and 7th week. Like initially in the first trimester it starts, peaks at approximately 9th week, and then resolves by 20th week. Okay, you need to remember these three figures. That is 4 to 7 weeks it starts, 9 peak 9, then resolve by 20. Okay, 4, 7, 9, 20. So these numbers you have to remember. It resolves by 20th week. In almost 90% of the women, it will resolve. Okay. So what are the objective assessment you are doing, and how can you ask whether she is having, how can you grade her? Like hyperemesis gravidarum or nausea or vomiting in pregnancy, you are having three things. That is mild, moderate, and severe. You are having three types of nausea and vomiting, NVP. So how you can determine? You can determine by two things, that is puke, that is pregnancy unique quantification of emesis, and new guideline has given another one, that is HELP. Not that HELP of eclampsia, that is HELLP. This is of preeclampsia. What is HELP of preeclampsia? Anyone?
Hemolysis, elevated liver enzymes, and low platelet count.
Yes, very good. So this is HELP of preeclampsia, but what is this HELP means is hyperemesis level prediction tool. Okay, this is a help tool for hyperemesis gravidarum. So these are the two tools or for the objective assessment. First, coming to the puke, that is pregnancy unique quantification emesis. So what you are going to do? This score can be used to determine whether the NVP is mild, moderate, or severe. You can just determine or you can just grade the NVP. But what happens, the most important thing is you cannot assess the treatment for severe NVP or hyperemesis. Puke is only used for grading. Grading of NVP can be done and assess the response to treatment in only mild to moderate situations. In mild to moderate situations only, you can grade the or you can assess the response to treatment by asking how many times you are vomiting now, is the treatment has worked or not, how many times you are retching now. So previously also you can ask, and then now also you can ask. Only in mild to moderate situations. Please remember, it is not valid for severe form of NVP. Okay, so you cannot assess the response for severe form of NVP. This is about puke. So let me show you this. What is a questionnaire you will ask? That is unique quantification of emesis index. So what is the total score? The total score, you will be adding all these three. Okay, you will be adding all these three. How you are adding? What are the three questions you will ask? Usually in the practical exams, they will not ask all this. They will ask only these things. So in the last 24 hours, for how long have you felt nauseated or sick to your stomach? It means how long? Nausea, how long? So you cannot remember the whole questionnaire. That's why we will remember in the short sentences. How long nausea? So 24 hours is common. You will ask the puke questionnaire for 24 hours. Like in the previous 24 hours, how long you have been nauseated. Then last 24 hours, vomiting. Last 24 hours, vomiting. So nausea, how long? And have you vomited? Okay, times of vomiting is been asked. Then coming to last 24 hours, how many times you have had a retching, or it means what is retching? The feeling of vomiting. It is not nausea, the feeling of vomiting. She's about to vomit, then she'll stop, about to vomit, then she'll stop, and then she'll be having some sensation in her, burning sensation in her esophageal region. That is known as a retching. Or dry heaves without bringing anything up. The same thing as I told, no, she might think of vomiting, she'll start it and then she'll again gulp it. That is known as the dry heaves or retching. Okay, so did you observe one thing? Here we have seen frequency in two things, that is times. How many times you have vomited? Okay, times of vomiting, like number of vomitings. Okay, and here number of retchings. Okay, I thought of vomiting 2 times, but I didn't get it. Then it was okay. If she says like that, then her score is 2. Okay, so only this thing is the duration. Like it means only for hours. She will say, "Oh, I had nausea for 2 hours. I have nausea since 3 hours." Like that, if she says, then you will be having a score. Okay. Just to get active for everyone, let's score one patient with puke index, and then you can say me whether it is a mild, moderate, or something. So a patient has come. She said that she had a nausea for about 3 hours in the past 24 hours. Okay, 3 hours. 3 hours of nausea in the past 24 hours. And then she told that she has vomited 6 times in the past 24 hours. Okay. And then she told that she had 2 times of retching. What is the puke score and how can you categorize?
I think it's a 9, madam. It comes under moderate.
Puke score, it comes under 9.
9 and it's a moderate.
Yes, correct. Very good. So, how can you say that 3 hours of nausea comes under? Yes, 3 hours of nausea comes under score 3. Then 6 times of vomiting comes under score 4. Then 2 times of retching comes under score 2. So, overall it is 9 and then it comes under the moderate scoring. So, coming to the scoring of puke, that is a total score is 24. Okay, total score is 24 and then mild is 6, moderate is 7 to 12, severe is 13 to 15. These points we have to remember because whenever you are going for a treatment, then in the post graduation usually we will not do so much of this. We'll just go for a clinical approach. But when coming to the viva, or if you want to go for a further clinical practice, or if you want to write any MRCOG exam, then this scoring part is important. Okay. Then help. This is a help tool. So what is help tool and how this is useful? It quantifies the hyperemesis gravidarum into a score. So first it will quantify into a score. Then it is used for to monitor and monitor the progress and respond to the treatment. So whenever you start giving the treatment, you are giving antiemetics, then you will again ask, okay, previously you had 10 vomitings, now how many vomitings you are having? Previously you had 2 hours of retching, now how many times you are having? So this is for the monitoring of progress and response to treatment. So in this we have learned that this cannot be used for hyperemesis gravidarum, but this help tool can be used for hyperemesis gravidarum to monitor the progress. So coming to the blood investigations, let me show you, this is the help tool. So in the help tool, there are so many conditions, like this is all subjective conditions. You will ask her how many vomitings per day, how many retchings per day, and then is she urinating or not, and then how severe it is if she is taking medication, or how severe it is if she is having after food. Okay, so just go through this. This is your homework for today. Go through the whole help tool and categorize if any of your patients coming, and categorize number of patients, different types of patients. Okay, so this is the weight loss, any number of treatment used for nausea and vomiting. Okay, so this is all about the help tool. Usually this is usually not important, but you can remember the severity scores. So severity score is 33 to 60. The severity score is 33 to 60. Okay, you can have a chart with you pasted in your notebook, so that every time when you when a OP patient comes with vomiting, if you just go through these two scores, you will get it by heart. You will there is no need to spend more time on this and let it by heart. Okay, just spontaneously you can go through this. Okay, now coming to the blood investigations that may reveal the hyperemesis gravidarum, or that may substantiate the hyperemesis gravidarum. So what are the metabolic disturbances you can identify is, you will be having a hyponatremia, you will be having hypokalemia, and urea will be less. Okay, and the ketones also will be positive, chlorine will be less. So why I am writing all this is, everything will be decreased except hematocrit. This is very important. Everything will be decreased except hematocrit. So hematocrit will be increasing. So whenever a patient comes with hyperemesis gravidarum, what is the metabolic abnormality she will face with? She will face the metabolic hypochloremic alkalosis. Why alkalosis? Because whenever she gets she vomits, all the chlorine in the acid, all the chlorine in the hydrochloric, all the HCl in the stomach will be washed out, which is leading to the decreased acidity. Decreased acidity means alkalosis. So she is landing up into hypochloremic alkalosis. So if it is becoming severe, then she might land up into the metabolic acidosis as a compensatory mechanism. So there is no need to by heart all the things like hyponatremia, hypokalemia, what is this, hyper or hypo, no need. Everything decreases except hematocrit. Okay. So these are the lab investigations. And another one which we can see in hyperemesis gravidarum or nausea and vomiting is thyroid function test will also be abnormal. So usually we will not have this in our mind whenever a patient comes with nausea and vomiting. So she complains of so much of vomiting, but if all the metabolic things are normal, but you are giving first line antiemetics, second line antiemetics, it is not decreasing. Please do thyroid function test. Definitely there might be a chance of she is having a hypothyroidism or something, because 2/3 of the patients will be having abnormal thyroid function test in cases of nausea and vomiting and hyperemesis gravidarum. So at such conditions, immediately you need to think of thyroid function test. And what is the other one? Liver function test also. So approximately 40% of the people will be having the abnormal liver function test also. So we have to keep in mind whenever a patient is having refractory vomitings. Refractory means it is not decreased with the first line of antiemetics. Then we call it as a refractory, first and second line. So then we need to think of thyroid function tests and liver function tests. Okay. Now coming to the another indicator, that is ketones. As I have already told you, ketonuria is not an indication of dehydration and should not be associated with the severity of nausea and vomiting. So if anyone says like ketones are 3 positive, then you cannot say, oh, this is a very severe NVP. No, you cannot say that. You cannot quantify or grade the NVP with the ketones. Okay. So if I am going too fast, please tell me so that I can slow down. Okay. So this ketonuria is not an indication of dehydration. This is the new point in the guideline. This is the new point in the guideline that they have noted about ketonuria. Next, coming to the how to approach a patient with hyperemesis gravidarum. So all these things you can write in your exam, you can present in your seminars, or you can go through in the practicals or viva sessions also. All these things you can apply in your clinical aspect also. So how to approach an NVP patient? So you can ask her in the history if she is having any previous history of NVP in her previous pregnancy. So the recurrence of NVP or hyperemesis is more, then you can quantify the severity with puke and help. You will ask her how many hours of nausea, how many times of vomiting, how many times of retching. Then you can quantify. Based on that, you can ask if there is any weight loss or if there is any hypersalivation. Such things you can ask. Then you can ask if she is tolerating food or not, if she is taking any liquid food or solid food. Such things also you need to ask. Then you have to ask about any rapid weight loss, and definitely you have to ask about the comorbidities, because some of the medicines that are used for the comorbidities like any epilepsy, HIV, psychiatric conditions, such conditions, what happens is whenever she is taking such medicines, they might cause gastritis, and that itself might lead to vomitings. Next, coming to any surgical history, if she is having any band or sleeve prior to that, like any gastric surgery, sleeve surgeries have been done, if she is eating in the pregnancy, or if because of the uterus growing up, if she is having any difficulty also, we need to ask about any surgical history. So all these histories we will ask, like you'll ask, you are you having any medical history? Then you will ask, are you having any surgeries prior? So such things you will ask. But you need to remember what are the things you are going to expect in this also, you need to remember. And we need to exclude the other causes also. If she says vomiting, if a pregnant woman says vomiting, you cannot blindly say, it's okay, hota hai, this is normal in pregnancy, don't worry, we'll give you some tablets, and then just rush into the OP. I know you all will be busy in the OP, but let me tell you, if a patient is telling so much about vomitings, and if she is not having her physical life balance also, then you need to pay caution about that vomiting. Okay, and we need to exclude the other causes because it could be some life threatening also sometimes. You need to ask if she is having any associated pain abdomen, if she is having any urinary symptoms. In UTIs also you will be having this vomiting sometimes, any infection, any drug history, any chronic helicobacter pylori infection like in cases of pyloric ulcers or something, peptic ulcers. So such conditions we need to be cautious about. So we have to rule out. That is the reason we have said in the definition, NVP is only diagnosed after ruling out other causes. After ruling out other causes only, you have to say that is a NVP normal one. Okay. So history is done. Now coming to the examination. So what you are going to examine? First, you will look for the regular vitals, that is temperature, blood pressure, heart rate, respiratory rate, such things you will see. And look for the signs of dehydration. Signs of dehydration. So, what are the signs of dehydration? Anyone? Answer A. So, the signs of dehydration is sunken eyes. You'll be having dry lips and mouth. Oliguria will be there, tachycardia and hypotension. So these are the signs of dehydration where you can immediately get caution with the patient, and you can go further with the evaluation. And then you will look for the signs of malnutrition also. If she is having any rapid weight loss, that is more than 5% pre-pregnancy weight loss has been there, or any muscle wasting is there, such things you will be noticing by measuring the mid-arm circumference also. So signs of dehydration. So first thing is vital signs. You know vital signs. The second thing is signs of dehydration. The third thing is signs of malnutrition. Okay, and then you will be having abdominal examination. Abdominal examination is to be done. Then neurological signs. So what are the neurological signs? Why you are worried about neurological signs? Because the hyperemesis gravidarum lands up into Wernicke's encephalopathy. It might cause Wernicke's encephalopathy. This is a very dreadful condition. The patient might have amnesia, or ataxia will be there, nystagmus will be there. So neurological signs also you need to ask, because you need to know how far the hyperemesis has been progressed and how quick you should respond. That is the reason we are also looking for the neurological signs. So such simple questions also can save the life of a patient. So this is about examination. Don't worry, if you are a person of taking running notes, you can take it. Otherwise, I'll send the PPT to the app also. You can go through in the app also. Coming to the investigations, as we have already discussed, the most important investigations, that is thyroid function test, liver function test, we have discussed. But for the investigations total complete sake, I'm discussing this with you. So urine analysis we have to know about, because any ketonuria could be there, and then nitrates, if it is there, it indicates the infection. Okay, and then the presence or absence of ketonuria is not an indicator of dehydration. Again, they have given here. It means that they have seriously taken that you cannot grade it by you cannot grade the severity by ketones. Okay. See here, assessing the urine ketones does not have a use in the management and may be misleading. That is the reason they have simply removed ketones. But it does not mean that you cannot do ketones. You have to do it, just for the sake that okay, the dehydration has been there or something like that. But this is not a diagnostic criteria. So midstream urine sample is to be given for the to look for the signs of UTI, urea and electrolytes. And then you will be looking for the potassium, sodium, everything, electrolytes you will be seeing for. Then full blood count is to be done to rule out any infection or anemia, or any raised hemoglobin or hematocrit. So as we have already discussed, all will decrease except hematocrit. So hematocrit or hemoglobin is raised or not, such things you can understand. Then the blood glucose levels. Why? Because sometimes diabetes also, diabetes, that is early diabetes, over diabetes, can cause vomiting in pregnancy. That is the reason you will rule out the diabetes also. Okay, and then you have to, if the patient is already over diabetic, and she is vomiting profusely, then you have to rule out the diabetic ketoacidosis also. That is the reason you will rule out the blood glucose levels. Then the most important is the ultrasound scan. So what might be the cause of vomiting in pregnancy? Obstetric causes could be twin pregnancy, it could be gestational trophoblastic diseases, molar pregnancies. So such things could be there. That is the reason you will be going for the ultrasound scan to look for if there is a viable intrauterine pregnancy or any twins or any trophoblastic disease is there or not. You have to check for. So I have told no refractory cases. Whenever the patient is not controlled with the antiemetics or there are history of previous admissions, immediately do thyroid function tests and liver function tests to rule out any gallstones or any malnutrition. Also, you have to monitor. And calcium and phosphate are also to be looked for. And to look for the pancreatitis, you need to check the MLAs. Okay. So venous blood for the metabolic disturbances also you need to exclude. So this is about the investigations. So all these are the common investigations you will do. Spontaneously you will write all the tests, but we need to know why we are writing the test so that you will remember it and you will never forget to write one test. Okay. So this is about the investigation. So far we have discussed how to approach the case. About history we have discussed. About the examination we have discussed what to look for in the patient. And then we have discussed about the investigations. Now coming to the management. So how do you manage the case? First thing, you need to differentiate what is it. So if the nausea and vomiting in pregnancy is there, and if this is mild or moderate, okay, if this is mild or moderate, first you will treat with the oral antiemetics. So you will try to treat with the oral antiemetics in the outpatient. So if she says mild or moderate, you will treat with the oral antiemetics. What are the first line drugs? The first line drugs, this is important. This is very important for your clinical practice, your practicals, your exam, everything. In your lifetime, you should not remember this, you should not forget this, sorry. So the first line antiemetics are doxylamine and pyridoxine. Doxylamine and pyridoxine should be there in the first line. Okay. So here you will be giving 20 by 20 mg, and then slowly you will be increasing additional 10 by 10 mg in the morning, 10 by 10 mg at the lunchtime if required. Then cyclizine. So these are the first line drugs. Cyclizine, prochlorperazine, promethazine, chlorpromazine. Such things are included in the first line. I will tell you small mnemonic to just remember which line of drug it is. So all the ending with zine, that is cyclizine, prochlorperazine, promethazine, chlorpromazine, all these are included in the first line. Okay. So dose usually we can remember for doxylamine, and for cyclizine also just remember it is 50 milligram per oral 8 hourly. 50 milligram per oral 8 hourly you can give. So if you are good at numbers, you can remember the doses. Otherwise, just you can write doxylamine and pyridoxine dose. Then you can write cyclizine, prochlorperazine, promethazine, and chlorpromazine. Okay, fine. If the patient fails to respond to the first line, then you are going with the second line. So what are the second line drugs? Second line drugs are also important. Metoclopramide, domperidone, and ondansetron. Do you remember now your favorite drug, that is ondansetron? This is second line. Okay, you cannot give it as a first line. Most of the times they say that the patients are having constipation, so a laxative should be advised. And it could be per rectal also you can give, or per oral also you can give. This is ondansetron 4 milligrams, 8 hourly you need to give. Coming to metoclopramide. So metoclopramide is important because you cannot give metoclopramide for so long, not more than 6 days. Okay, not more than 6 days, because the metoclopramide will cause extrapyramidal symptoms. Extrapyramidal symptoms like lip smacking, or the patient is having some neurological signs. That is the reason metoclopramide cannot be a first line drug, and it cannot be used rapidly like that of ondansetron. Okay, so extrapyramidal symptoms is important here. It causes extrapyramidal symptoms if given more than 1 week. That is the reason you will just use it with caution. Okay. Now coming to the third line drugs. So third line drug is the corticosteroids. So corticosteroids should be reserved for refractory cases where the standard therapies have already failed. You have already used the all the antiemetics. You can just add first line and second line, or you can have two first line drugs, or you can have first line one drug, second line plus second line. You can use like this. So number of combinations are there. Trial and error method you can use it. But if all the methods fail, then only the corticosteroids are to be implemented. So what is a corticosteroid that is used here? That is hydrocortisone 100 mg. Twice daily IV is to be given. So whenever there is a clinical improvement, so everything is fine. Whenever there is a good improvement, then convert it to prednisolone oral. So the IV is converted to oral prednisolone. IV you will giving hydrocortisone. If she is fine, 100 mg BD IV, she is fine, then you will be converting into prednisolone 40 to 50 mg daily. Slowly you will taper the dose, because corticosteroids you cannot immediately stop as okay she is fine, then you can stop it and you can ask her to go home. No, you have to taper her slowly till 1 week, and then you need to keep the lowest maintenance dose where the symptoms are being subsided. The lowest maintenance dose where the symptoms are being subsided, there you have to stop that, and then you can slowly taper. Okay, so these are the first, second line and third line drugs. Okay, we will again revise it at the later end of the class. I will be asking you questions also. Okay, you have tried all the oral antiemetics. Then you need to have an inpatient criteria. So still she is not having control over the vomitings. She is not eating anything. She is not taking even fluids also. She is not having anything like liquids also she is not having. And her blood pressure is around 80/40, and all the metabolic abnormalities is there. Then you cannot afford to have an outpatient treatment. You have to immediately admit her. Okay, what are the criteria? The guideline has specified some inpatient criteria. So what are the criteria? Continued nausea, at least one should be there. One is enough to have an inpatient. See how much importance they are giving for the inpatient admission, because it is a life threatening situation if you cannot uh, treat it at the correct point of time. You have to identify it clearly immediately. So at least one should be there, that is continued nausea and vomiting and inability to keep down the oral antiemetics. So the pregnant woman's mother will say, usually the pregnant women will not talk, the surrounding people will be talking. So the pregnant woman's mother will say, no, she is not eating anything, she is taking ondansetron and she is vomiting. It means she cannot keep down the oral antiemetics, and continued nausea and vomiting is there. That itself is the it shows that she needs some IV antiemetics and inpatient criteria. Then continued nausea and vomiting associated with clinical dehydration. If there is a dehydration and if there is a weight loss, despite oral antiemetic, she is using oral antiemetic, but still she is having a weight loss, that also will show the inpatient criteria. And if she is having any comorbidity, like you suspect a comorbidity or she might have a confirmed comorbidity, both can be there, such as urinary tract infection or inability to tolerate the oral antiemetics, such things could be there. And any comorbidities such as epilepsy, diabetes, HIV, hypoadrenalism, such things are there, then also you have to admit her and then you have to treat her. And all the psychiatric diseases where the symptoms and inability to tolerate the oral intake and any medication which could have the further complications also. Some psychiatric patients, they cannot take orally, and some further complications also could be there because of oral medication. At such points also you will be admitting the patient. So these are the inpatient admission criteria. This is also very important. I will be sharing you the PPT as well in the app. Just go through it and read it today itself. If you are interested, you can read the guideline also. So most of the guideline things we have incorporated in the PPT to make you simpler. And if any question has been asked in hyperemesis gravidarum, now you can write at least 10 points about it. So that is the reason why we make the PowerPoint presentations very crisp. We will not read all the lines of the article. We will not paste all the lines of the article in the PPT. We'll make it crisp so that you will understand easily. Only the important points you can remember. So this is the very important slide. Go through it even after the class. So the whole crisp of the article lies in these two flowcharts. So what the guideline is saying, or what how you can approach the patient, how you can treat the patient is something like, so first is the initial assessment, okay, then is the management. These two things are different. Initial assessment, so immediately whenever the patient comes, you will, what you will do, you will diagnose it first, and then you will assess the severity. How you can assess the severity? By puke score. If it is hyperemesis gravidarum, you will take the help tool also. So both tools you can use, you can coordinate. Then you will record the weight, because if it is more than 5% loss of the pre-pregnancy weight, then it is an admission criteria. That is the reason you will record the weight. Okay. Then what happens? Based on the puke score, you will manage it. So if the puke score is 3 to 12, so what is 3 to 12? 3 to 12 is mild and moderate. So both comes under this thing, and no complications. No complication is there. Then what can you do? Antiemetic therapy. Okay, I'm zooming it. Okay, so you can manage it in community. Community means only OPD. Like antiemetic therapy could be given, and you have to reassure that all it is because of you are giving evidence-based medicine only, because of guidelines only you are giving, and reassure her the safety, so that if at all she is not taking any antiemetics due to the fear of teratogenicity, that might get less. Okay, so you reassure her that this is fine, and then encourage her oral hydration and offer dietary advice. Just she can have some frequent meals, but with less amount. Okay, you need to counsel her to eat little. Then consider the use of laxative if required. Prescribe the histamine type 2 receptor blockers or the proton pump inhibitors. If she is developing GERD due to the vomitings, if she is developing GERD, you can also prescribe the proton pump inhibitors. Then mental health assessment is also important, because any psychiatric problem also can lead to this. So mental health assessment also important. Then you cannot leave the patient to okay fine, you can come after 1 month. No, you have to reassess her after 3 days. Like whenever she is nearer to your hospital, you can ask her to review after 24 hours, like after 72 hours, based on her condition. If it is mild or moderate, based on the condition, you can reassess after 24 to 72 hours. If it is improving, then it's fine. But if there is no improvement, then add another antiemetic. Add a second line antiemetic or a third line antiemetic. Add a second or third antiemetic in the first line, second line, and you just help titrate those drugs and titrate those antibiotics. And if any red flags are there, you can immediately tell her to admit in the hospital. So you need to tell her all the red flag signs, what can she experience. Okay, the red flag signs are here. Any puke score with any complications, or inability to tolerate the oral intake, if she is unresponsive to outpatient management. So all the things which we have discussed in the inpatient criteria, such things all are the red flag signs. So at such point, what you are going to do, you are admit the patient. You are going to admit the patient. So this is puke 3 to 12. Then what happens if the puke score is more than 13 and with no complications? Complications are not there, but she is not taking orally. Then go for an ambulatory daycare management. So in the daycare management, it means you are going to admit the patient. So what you are going in the daycare management, you will insert a cannula, blood test will be sent. So what are the blood tests you are going to send? You will send CBP, you will send hemoglobin hematocrit, LFT, RFT, LFT, TFT, such things, everything you will send. Then IV antiemetics you will prescribe, IV fluids for to combat dehydration. Like what are the IV fluids you are using? 0.9% saline you will use. Okay, and if she is experiencing any hypokalemia or hypochloremia, you will add the potassium chloride also. 20 millimoles of potassium chloride over 1 to 2 hours you will be adding. Thiamine supplementation. Why thiamine? Why thiamine? To prevent Wernicke's encephalopathy. Okay. No dextrose is to be given. No dextrose is to be given. You cannot give a dextrose because it will further aggravate this condition, Wernicke's. So you might have a doubt. Favorite question of all the examiners, whether you can give multivitamin before or thiamine before. In our setups, we will give thiamine and multivitamin. So which one is the first? Thiamine should be the first, because after giving thiamine only, so the deficiency of the thiamine will be reduced and there will be no progress of Wernicke's encephalopathy, and this will prevent the Wernicke's encephalopathy also. So that is the reason only thiamine should be given first. Then if needed, you can give the multivitamin combination IV regimen also. Okay, such things you will give in the emergency or IP management. So this is the first initial assessment only you will do that. Coming to the management, so this all is same, and only the management here is first line, second line, third line they have given separately. Okay, and the ambulatory daycare management is also same. Okay, and the emergency department you will be doing. So what are the other considerations you will be doing? You will be up titration of antiemetics. So whenever a patient comes and says, no, I'm having vomiting, I cannot reducing, it is not reducing the doxylamine, then you will add ondan also. Ondansetron also you will add. Okay, first initially select a first line antiemetic. Then you can use combination of drugs if she is not responding to a single antiemetic. Okay, you can add drugs, you can oppose to them. Okay, you can play with the antiemetics. So for all patients who develop GERD, you can use the proton pump inhibitors. All are safe in pregnancy. So proton pump inhibitors you can use. Thiamine supplementation you have to give. Laxatives you have to give. And then VT risk assessment is also important, because whenever she is landing up in dehydration, so pregnancy itself is a hypercoagulable state. So immediately she might land up into a thromboembolic disorder. That it means she might land up into any embolism also. So we need to have some risk assessment also. So this is all and all about the management, how to have a management. Now coming to the obstetric outcome. So why you are worried about hyperemesis gravidarum? It's okay if she vomits, okay, then fine. Why you are worried so much about hyperemesis gravidarum? Because there is a risk of miscarriage also. After having so much of vomiting, she might have a risk of miscarriage. And what are the complications she might face? She might have Boyer-Haft syndrome also. So after having so much of vomiting, she might experience the esophageal tears also. Esophageal tears also could be there. That is the reason. And obstetric outcome, most of the times it will be normal. Like with prompt diagnosis and treatment, it will be normal. But if there is a risk of abortion is also there, and MTP is not recommended for hyperemesis gravidarum. MTP is not recommended for hyperemesis gravidarum unless until if the patient is not having stable or hemodynamically stable. If she is not stable, or if the hyperemesis is not subsiding with any of the things, then only the MTP could be decided by at least 2 consultants. Okay, MTP is usually not recommended. If she is having any Wernicke's encephalopathy, then you can think of MTP by having a discussion with 2 consultants. So this is about the obstetric outcome. Okay, clear till now? Yes, this is this itself is the crisp of the guideline. The guideline shows at least 60 to 70 pages. There is no need to mug up or read all the guideline, because you won't have so much of time to read. So we'll make it crisp. You can learn it. You can revise it, read, revise, repeat. So every time just revise it. Okay. So yes, can anyone tell me 1 or 2 drugs of first line, second line, and third line? First line. Second line, sleepy. Third line, anyone is sleepy? Yes. First line you can say doxylamine, pyridoxine, then promethazine, all zins. All zins come under first line. Then second line comes under ondansetron, metoclopramide. Third line is hydrocortisone and prednisolone. Okay. So yeah, yes, that's all for today's class. Thank you for your patient hearing. So I'll be posting this in the YouTube channel also, and in our groups also I'll be posting the PPT. So just go through the video, and just go through the guideline also if interested. Go through the tables and all the scores you can see. And we have kept a protocol also for hyperemesis gravidarum yesterday, so you can just have a look on it. This is taken from this guideline only. Okay, and then we have courses regarding the MS and DNB courses. Regular courses are there, previous year questions courses are there. Just go through the app and go through the courses. We are having the anniversary offers, and these are ending at 28th of February. You will have end of the anniversary offers. In this week, 8th February, we are closing the early bird offers also. So early bird offers will be closing by 8th Feb. Don't worry, we can give you the affordable prices. So I'll be posting separate videos of all the courses where you can have what and what are the contents inside the course also. I'll be posting it. And yes, EMI offers are also available. So if you want any EMI offers, you can directly text me so that we can have a feasible duration of EMI. Okay. Thank you for your patient hearing and happy learning.